morning, everybody. Thank you for inviting me to give the talk here. I'm Charissa. I'm one of the associate consultants in KK Hospital in the Department of Reproductive Medicine. So today we are talking about. Okay, today our topic that we are talking about is oncofertility, fertility preservation. So the most important question, first of all, is fertility important? And without a doubt, definitely it's important. Otherwise, my department will be out of business. But beyond that, actually, I do feel that there's really a growing need to address these fertility concerns among cancer survivors. And this is because of multiple factors as shown. Number one, there's an increasing incidence of cancer, and this has been described by Dr. Mikael as well as Dr. Joanne. The main thing is, our numbers for cancer have increased by about 6 times since the 1970s to now. The good news, however, is that we are actually detecting our cancers early. And with early detection, it tends to be early stage. Of course, there's more room to grow for that. We hope that we will continue to get earlier detection, better screening. But at the moment, at least, we are getting more and more early cancers instead. And because of early stages of cancer and better treatment modality, there's actually better long-term outcome and better long-term survival. So our cancer patients now are living longer. That being said, as a group of us, we do know that with cancer treatment, there's always some negative impact on fertility. More so, fertility is an important question to all women because as a population, women are nowadays choosing to get married a bit later. We are also choosing to start a family later. So fertility is of importance to females in general, and more important to our cancer patients. And as a whole, for the cancer survivors, we are actually asking, now there's more research putting forward to improving just more than just survival outcomes that we are looking at nowadays. There's a growing need to address, there's a growing importance that we need to address the quality of life and survivorship of our patients with cancer. So this graph actually shows the ovarian reserve with time. So as we know, in the green line, we are born with a definite number of follicles, which decreases with age. With the use of chemotherapy or radiation, there is a sharper decline that post-treatment. Yeah. This other graph actually shows that the decline of fertility is dependent on multiple factors, which includes what kind of therapy that you're going to get, and also the pre-treatment ovarian reserve. So the first graph on the left actually shows the type of treatments that some breast cancer patients may get. The green line shows tamoxifen. So if you're just using tamoxifen alone, the green line shows that the fertility decline is not significant, it's more or less stable. But if you're using chemotherapy agents, AC-based or CMF-based, the decline is sharper. And this is it can prolong up to even 24 months post-chemotherapy. The second figure that we are showing on the right shows how the ovarian activity declines. And this depends on how your ovarian reserve at the start of treatment. So the green line shows the patients with high ovarian reserve. There's definitely some anticipated decline during the treatment itself, but there's a recovery period where there is recovery of ovarian function thereafter. However, if you started with a low ovarian reserve, the cytotoxic drugs may actually push the ovarian activity below the POI threshold. POI threshold is basically premature menopause, and such patients may not be able to recover their ovarian function post-treatment. So this becomes this is one of the growing fields in our center. So this is a topic of fertility preservation. Are there any options available for these women before they start any gonadotoxic treatment? So the options available are either egg storage, embryo storage. Okay, we also can harvest ovarian tissue for storage. Finally, there are certain medications that can be used before chemotherapy. These are injections that suppress the ovarian function and at least decreases the risk of chemotherapy on the ovaries. So I'll first describe the egg storage and embryo storage options. This is the most studied in literature. So egg storage and so egg and embryo storage basically entails a IVF procedure. It itself is not a easy procedure for any women to undergo as well. The first thing that we will do is you'll be referred to the reproductive medicine team, the IVF team. We'll do a consultation. It's always, I mean, if you are in a relationship or have a husband, you should always bring your husband along. We'll do basic preliminary fertility investigations. And if the couple is suitable, we would actually proceed with stimulation. So ovarian stimulation involves actually multiple injections. So like I said, it's not an easy process to go through. Okay, it's both physically and mentally draining for the women. So the patient has to do about 8 to 12 days of injections, daily injections. And every 2 to 3 days, you would have to come back to our center to do an ultrasound to monitor the sizes of the eggs. Once the egg is of appropriate size, okay, we will actually do a mini operation procedure where we would do an ultrasound, use a needle to harvest the eggs. So on the day of egg harvesting, the husband would then be giving his sperm as well, and then we will fertilize the egg to form an embryo. So there are many options for ladies. I mean, if you are not married, there's always options to just store as an egg. If you are married, there's an option to undergo fertilization and store as an embryo. There's some pros, there's some cons. In terms of, I mean, by and large, we do feel that the embryo is hardier. So roughly 3 embryos gives you a chance of a pregnancy, whereas you are expected to need about 8 to 10 eggs to get a pregnancy. And of course, each woman's quality of egg and egg reserves does differ. But one of the drawbacks of actually storing as an embryo is that embryo requires, first of all, a married couple, and the couple do need to remain married if you were to use this embryo in future. So a lady needs to be aware of this. So the next option we are going to discuss is the ovarian tissue storage. So ovarian tissue storage is basically harvesting some ovary and storing this ovary the same way we store the eggs. Once your treatment is completed and you are safe to carry a child, this ovarian tissue is then transplanted back into the body. So so in this case, the lady actually requires surgical procedures, 2 at least. One is to harvest the ovary, and then another to transplant the ovary back. There are certain plus points compared to egg and embryo storage. One of it is because when we transplant the ovaries back, it continues producing hormones for the girl. So if the ladies experience some menopausal symptoms, this can help to alleviate some of the menopausal symptoms. If the transplant is back to the original site, potentially there is chance of naturally conceiving the pregnancy and not requiring IVF. That being said, even in literature, most women do opt for IVF still because of the time frame for pregnancy. There are certain drawbacks. One of the biggest drawbacks, of course, is the surgical procedure and risk involved, because it at least involves 2 surgeries. There's also a theoretical risk of tumor seeding. So for all the ovaries that are harvested, a portion is always examined for whether there's any cancer or not. But of course, this is not 100%. And second factor to consider would be things like genetics. So if for especially things like BRCA1 carriers, there are increased risk of ovarian cancers. So theoretically, if you do transplant any ovarian tissue back, there's this risk of ovarian cancer in future. And last but not least, it may not be suitable for everyone. Usually, we don't recommend it if there is low ovarian reserve or higher age, more than 36. Okay, last but not least, I will discuss certain medications that can be used to suppress the ovarian function, and this is to protect the ovaries during chemotherapy. So this group of injections are known as GnRH agonists. So what does GnRH agonists basically are injections that simulate a time of menopause. This is a reversible menopause because once the injection wears out, your ovarian function resumes. So while you're on the medication, the ovaries are put into a state of hibernation. Therefore, there are studies among breast cancer women that it improves. There's improvement, or rather, there's a decrease in premature menopause with women on that use GnRH agonists. However, this is still there's still very limited data in literature. More and more data is showing that there may be improvement of ovarian function, but there's even less data on pregnancy outcomes thereafter, because a lot of these studies actually use premature menopause as an endpoint. Whereas we do know that even with the recovery of ovarian function, it does not equate necessarily to fertility. Yeah. So at the current moment, the first three techniques, as mentioned earlier, should be the primary options, and injections by itself shouldn't be the only option offered to the patient, okay? Unless, of course, it's the patient's wishes for various reasons. Okay, so these are important discussion points as a patient, questions you may want to ask your medical oncologist, your breast surgeon, or your fertility doctors. So we do know that cancer and cancer treatments does impact fertility, but there are many factors that come together to see whether this risk is high or low, like your stage of your disease, the type of cancer, your pre-treatment fertility, what kind of treatment are you anticipating, what is the follow-up before you can get pregnant. Giving an example, you can have a 25-year-old lady with stage 1 breast cancer who just need a lumpectomy without further treatment. In such cases, there's no impact to her fertility in that sense. She may not want to pursue this option. On the other hand, we can have a similar patient. She's 38, 39 years old, just married, and with stage 1 breast cancer. She may not need any further chemo, radio, even tamoxifen sometimes, but because of follow-up, a girl needs to usually follow up with the medical oncologist for at least 2 to 3 years of disease-free interval before trying for pregnancy, and then she's worried now she's 42. Yeah. So those are, the bring-home message is that if you have any fertility concerns, it's always good to bring up to a fertility doctor. And usually we will work together in a multidisciplinary team to see whether this option is suitable or not suitable for you. And like I mentioned, the second option is because a lot of a breast cancer patient goes through many things beyond just the cancer diagnosis. It's planning for reconstruction. It's also planning for chemotherapy. It's also potentially trying to preserve fertility. So before wanting to start any cytotoxic drugs, it's always good to discuss your fertility options and have an idea, and come to see us as soon as possible. So that we can advise accordingly. In terms of safety data, the data is limited, but it's very reassuring at the moment. There's no known, increased risk to the pregnancy, even for, it doesn't worsen any survival outcomes. And in terms of the pregnancy itself, there's no implications to the pregnancy itself, unless, of course, there are certain genetic predispositions. So, back. Back one slide. Yeah, so other considerations that you would have in your mind that I will try to address a little bit now. Number one, cost. Yes, everything in Singapore is very costly, especially IVF. So the procedures for egg banking or embryo banking, they are costly. Each time you go through the injections and the collection and the storage, one cycle costs about $12,000 to $15,000 in Singapore. That being said, storage also comes with their cost. So cost of storage is about $500 a year. However, nowadays you can use MediSave to cover a component of it, and if you're married, there are IVF grants available. So again, come to us, talk to us about it. We can always go through the finances again for each couple. Safety and pregnancy, like I mentioned above, usually we'll work together with your medical oncologist. During your pregnancy, we'll also be working with the high-risk obstetricians. They are the high-risk doctors taking care of pregnant women. Of course, in terms of globally, there's no increased risk, but of course, certain chemotherapy agents may have impact on, say, the maternal health, like heart health. So those will require a high-risk team to take care of you. But you can get pregnant after breast cancer treatment. And then success rates, like I mentioned, oocyte, or rather eggs, you need about 8 to 10 for one pregnancy, whereas embryos, you need about 3. Risk of fertility FP procedures, mainly either the surgery risk, where you need to cut the ovaries, whereas the other one involves injections, so it's uncomfortable, and you need a mini operation still, operative procedure to harvest the eggs. And last but not least, of course, every individual have their own preference. So in fertility, we always say there is no wrong or right answer. We have to individualize each person's treatment to their concerns and their situation at that time. So I want to share some data in our center. We have been doing FP from way beyond, more than 10 years already. I'm glad to say that actually our uptake rate is coming up, so it shows that we are actually hoping to get more referrals as well. We have seen 29 patients who actually underwent fertility preservation. Their age range from 16 to 40 years old. Most are married, 65% are married. Most did not have any children yet, so 89% had no children. And most of our patients that are referred to us are actually breast cancer patients, 44%. The good news, looking on the graph on the right, is basically the blue line shows the patients who are actually wanted to take up fertility preservation. The orange line shows that most actually are successful in harvesting either some oocyte, ovarian tissue, or embryos. And the yellow line, the yellow graph, which is the graph on the most right, shows the number of successful live births we've had so far. So we have 3 successful live births, and then 1 along the way. So if you wanted more information, we actually have pamphlets. We actually have a written article online as well. You can search it, and basically it gives you similar information on fertility preservation. Are there alternatives? There are alternatives. Number one, some women may not choose to have this option. They could choose for expectant management. We can always wait for ovarian recovery and then attempt natural conception. Of course, if women post-chemotherapy experience premature ovarian failure or premature menopause and have insufficient eggs, there's the option of a donor oocyte. That means getting another lady to donate an egg. You still can carry the pregnancy. And of course, other options like adoption, or some people may opt not to have children, which are all fair options. Yeah, so this is our workflow for the doctors. Basically, patients are also able to self-refer yourself. So so the workflow is that, call up the IVF center. We'll receive a call. The appointment to see a doctor for fertility preservation is very fast. It's within a week. We usually try to make it within days. And then the girl will undergo counseling, okay? And then if they are ready and are keen to go for fertility preservation, it would be started as soon as possible. Of course, fertility itself is not the only concern of women post-breast cancer treatment. So what are other what are other women's concerns? Post-chemotherapy, radiotherapy, sometimes there's its impact in sexual function. So we have a specialized sexual health clinic that you can get appointments to if you are facing difficulties being intimate with your partner. Another clinic that we have is the menopause clinic, because of the fact that chemotherapy sometimes can lead to premature menopause. So the menopausal symptoms can be very taxing. There are certain medications, lifestyle habits that can be modified to help to alleviate these symptoms. Other important factors beyond that, menopause also impacts our health. We do need to watch out for high blood pressure, diabetes, high cholesterol, as well as osteoporosis, bone health. So this is a clinic that specializes in managing these patients. So in summary, there's definite increase of awareness as well as fertility concerns in our cancer survivors. And fertility preservation may or may not be for everybody, but it should always be individualized to each patient's need. If fertility is even a concern, get a referral early to see us. And last but not least, always remember that fertility discussion doesn't just go beyond the pre-cancer treatment. People assume that it's only before chemo that it should be discussed, but no, it should be a discussion that we hold for a lady throughout her fertility lifespan. So even after your breast cancer treatment, if there's any concerns, it's always good to see us as well. Yeah, that's all. Thank you.